risk stratification, in my opinion, is one of the most critical things in the art of treating a patient with lymphoma. In my opinion, everybody is different. Everybody's tumor is different. In some cases, in almost all cases, each patient's tumor in different part of the body of that patient, they are also different. So risk stratification is lies in the heart of the therapy. When we do clinical trials, we usually use one therapy or two therapy to treat many patients. But although the patients are labeled with the same diagnosis, let's say mantle cell lymphoma, but actually the mantle cell lymphoma in each patient is different from the next patient and among all the patients. Therefore, when we treat all these different patients with one or two therapies, some patients with low risk factors get overtreated. Some patients with high risk factors get undertreated. So you can see that then we even, the one in the middle usually gets the right therapy. And but right, every cohort, low risk cohort, moderate cohort, high risk cohorts could be further risk stratified. So risk stratification, it is one of the most important things in the daily practice to treat mantle cell lymphoma. That is my opinion. So for mantle cell lymphoma, the risk is high risk features include p53 mutation, high KIC7 over 30. Some people think over 50 is even a worse prognostic population. And we also have patients who have complex karyotype. That means they have chromosome abnormalities, excluding 11-14 translocation. There are 3 or more chromosome abnormalities we call the complex karyotype. And then the mantle cell lymphoma morphology is also important with the blastoid pleomorphic being the high risk. So the high risk include, in summary, p53, KIC7, pleomorphic blastoid karyotype, or complex karyotype. This is only the beginning of what I'm describing. There's actually how to risk stratify is more complicated. There's MIPI scores, there's additional gene mutations, there is a bulky tumor load, there's also remissions within the relapse within the 24 months. Those are all data-driven risk factors. So that's why it's very complicated to treat a mantle cell lymphoma patient. And so the patient who has 3 prior therapies, they automatically has transformed into a very complex high-risk mantle cell lymphoma. Those people who treated with 3 prior therapies, including the BTK inhibitor, they only have about 6 to 10 months to live. So the risk stratification is complicated already, but their high risk factors continue to grow with the more genetic testing and more data from trials and from daily practice. MIPI score basically it takes consideration age, performance status, and LDH and the WBC, and those are very MIPI has been confirmed with almost all the clinical trials. MIPI is a very, very important prognostic factor. I think one of the main reasons that MIPI is so reliable is because it considers the age and also performance status, and in addition to other laboratory parameters. So the Swedish people has published many patients saying that age and the performance status affect not only failure-free survival, but also overall survival. So MIPI is very, very important, especially when the patient is newly diagnosed. And when MIPI is combined with the KIC7, that's even more reliable. It's really able to categorize the survival of the mantle cell lymphoma patient very nicely and neatly. But most of the times, the clinicians don't calculate the MIPI. If you treat mantle cell lymphoma treat lymphoma for every day, and you already feel you already automatically, intuitively categorize the patient in different risk factors. And when you calculate them in the MIPIs, your clinical intuitions, 90% you're consistent with the MIPI. So I think MIPI is very useful, especially when we publish some papers, some published data. MIPI is very important to see, to gauge, to calibrate whether this patient population is actually a low risk population, a moderate population, or a high risk population. In my opinion, MIPI is very useful.